So if you could see, it's hard to see, but if you could see, this is the 45, but then looking at the opposite side where the kidney is very little to 500 or 1,000 centigrade, which is an acceptable dose of radiation to cause minimal damage to the kidney. So doing the newer procedure, or the probably becoming more commonly used, a pleurectomy and decortication, if somebody comes to us that their cancer may have already be over multiple areas, or there might be lymph nodes involved, or they just have other comorbid factors. They have COPD, or they have emphysema, or they have heart problems, or lung problems, and they can't tolerate undergoing the whole lung removed on that side. Radiation can be aimed at just those spots where the tumor is affected. And the surgeons may go in and they remove the lining of the lung but leave the lung there. So it allows the patient to have function of the lungs on both sides, but removes the tumor. But then the difficult part comes in trying to aim radiation at those areas but spare the lung that still remains there. So in patients that have mesothelioma that has undergone the extrapleural pneumonectomy, we try to target. We have to, again, be very, very careful in how we aim the radiation, and we want to target the risk areas. And our surgeons go through with our radiation oncologists where the tumor might have been left behind. And this is another way of trying to aim that radiation. So we're not hit, so the lung is here, that's the area in black. So we have to try to limit how much radiation this gets. So in this patient, this part in white, because it was deemed area at risk, got 6,000 centigrade, but areas close to it, 4,000, 3,500, and then quickly falls off in the dose of radiation. And all these beam angles are used to aim at the patient. Because then we can use the target as what gets the highest dose, but the other things in between the target get a lesser dose. And allows, as you can see, allows you to spare. This is the liver, so allows you to spare the liver from getting hit, by radiation. This is just looking at it from another beam angle, and all this area is what is treated. Again, from sides, it looks like a road map, but our target is here in the white, here, and then the rest is the margin that's put around there. And this just shows lower in the lung, in the periphery here. And this is a same thing, but a different patient. This disease involved both sides of the pleura, medial and the lateral pleura, but the lung remained behind. And so we have to, it's a challenge to give the radiation, but try to avoid the lung in the middle here. And this is just looking at it from the side view and looking at it from an axial view. And this is heart, so we're trying to limit the amount of radiation that goes to the heart to avoid problems in the future. This is just showing you the detail of just how each plan is made. And when we do these simulations, to actually get a plan ready may take a week to 2 weeks, because our physicists will make a roadmap and they'll show it to the doctor, and the doctor will say, no, it's not good enough. I need less dose to the heart or less dose to the opposite lung. And it's just going back and forth between the doctor and the dosimetry and physicist team. So this is looking at just a 3D view of how all of those beam angles, this is, if you can see, this is the base of the head of this person. These are arms. The mesothelioma is on this side, and every one of these is a beam angle that's being addressed at this patient. And the hottest part would go where all these angles intersect, and then less radiation would hit the individual angles, so that we can spare the toxicity to those areas. So the practical things for patients when they come to MD Anderson, we have to plan radiation. We have to, because the targeting is very important, we have to set up. We have to do a simulation planning session. And after we meet patients and go over their scans with the surgeons and they agree to the radiation, we schedule a simulation. And it's our means of creating and reproducing exact targeting from day to day. So this is our simulation, one of our simulation suites. Our patients are set up on this table. There's a bar that they're holding onto, a foam cast that hardens once they're positioned and their spine straight, and the areas of interest are determined. And then the patient slides in and out of this. This is a CAT scanner, so it's going to make that CAT scan of them that the doctors will then use with the PET scan and information from the surgical procedure or from the laparotomy or whatever was done, biopsy areas. This is that cradle or vacuolock that the patients lie in. So it's like a foam cast, and it's soft at first. They lie people in it, and once they have it in the position that they like, then air is removed from the foam cast, and then it holds its shape. So day to day, every day, the patient is laid in this same cast. They have marks on their bodies, tattoos on them that are used to pinpoint exactly how they were set up the day before, and they go through this every day. This is the bar that they're holding on to extend their arms up as high as they can. The head would sit here, shoulders, and then the back. And these are just line marks that they use laser lining. So the patient lying here, the laser would come this way, and then one would come from head to feet, and where they intersect would be our target externally. So we know that internally all the pictures that are being taken at this procedure are conformally being arranged, but to help the therapist line the patient back up, they can know if the mark lines up to this is where they're straight. They go outside the room, check the images, make sure that everything is straight, and then they can proceed.